And what I've talked about so far is more just septoplasty and turbinate reduction, notwithstanding the anterior septal reconstruction procedure. I've alluded to the internal valve and the external valve. Let's talk a little bit more about that. First, word about functional rhinoplasty, and if it seems like I'm talking about this a lot, it's because I really want to get the message across about the functional nature of some nasal surgery that we do. We use a similar approach to what we do for cosmetic rhinoplasty. We lift the skin of the nose and look at the bony cartilaginous skeleton. But our goal when we manipulate that skeleton isn't just to take down a bump or do this or that. It's actually to improve nasal breathing and not aesthetics. We want to strengthen, and in some cases widen, the nasal skeleton so folks can move more air through their nose. And any changes in the external appearance of the nose are not done solely for that purpose, the purpose of changing the shape. They're done for expanding the nasal airway. In some cases, the nose may look straighter, as I showed you earlier, but it's certainly not the primary intention of the surgery. It can be done at the same time as aesthetic surgery, but in the cases of pure functional surgery, it's not. Now, the internal valve was described back in the 60s or 70s, and someone had the idea of looking up into the nose and noticed that there's this angle here. This is looking up someone's nostril. I hope they're asleep because that doesn't look very comfortable. But the angle here between the septum and this upper lateral cartilage, and thought that, well, the normal should be 10 to 15 degrees, and if it's narrower than that, then they've got an airway problem. Well, I've yet to see a protractor that'll fit up into someone's nose and measure, and I've really never been able to do that. So I think the real measure of the internal nasal valve, and valve is probably a bad term because it's not really a valve, is that this area of minimal cross-sectional area at the intake point of the nose should be thought of as the internal valve. And it's more than just this angle up here. It actually involves the lateral sidewall and the turbinate itself, as well as the septum. So if the septum's deviated high up here into this area, we would call that a valve problem. If the turbinate is enlarged in addition to this, and this is narrow, we'd want to address all these things to optimize the nasal airway through that valve area. Simply addressing this without at least looking at the others to see if they need to be addressed would be a mistake. The classic description for improving the nasal valve would be addressing that angle. So in this picture taken from one of the textbooks, this angle is improved by making incisions up in here and expanding this airway by placing grafts of cartilage taken from a portion of the septum that we don't need for support, for example, or from the ear, and expanding this angle such that we have less narrowing up here. As I mentioned, usually this is done in combination with other things. In very rare cases is it done by itself. This is one of those rare cases. This is a patient who'd come to me after having had an aesthetic rhinoplasty in the 1970s and was very happy with her nasal appearance but just couldn't breathe. And on exam the turbinates were fine, the septum was fine, but this angle was narrow. It's one of those rare cases where it was really an isolated thing. And you know, by trying to preserve her nasal airway, but really expanding this area by about 1 millimeter on each side, this is the mid-vault area underneath with those spreader grafts, she actually got a tremendous amount of relief. Again, the radius to the 4th power, very small changes in the nasal radius of that tube can make a big difference in the nasal airway. And if you thought the external valve was hard to grasp, I think the external, if the internal was hard to grasp, the external may be a little bit more so. This external valve is probably even a poorer term, as it really should be called lateral wall support problems. And this lateral wall support of the nose is influenced by the connections to this piriform aperture bone out here, this upper lateral cartilage area, this lower lateral cartilage we call it, and this fibrofatty tissue. Weakness in any of these areas can cause the nose to collapse on inhalation through here. And that's what's called external valve collapse. But rather than call this external valve collapse, and you may hear, I may slip up and use that term because it's really the more common term, I think of it as lateral wall collapse, and I think of 2 different zones where this can be occurring. The upper zone is called zone 1, and these are really 2 classes of patients in my experience. And patients with zone 2 collapse, it occurs a little bit lower, more along the alar rim and the nostril, and there's a different set of patients and different set of treatments that we perhaps would use for those for those folks. This is an endoscopic intranasal view of zone 1 collapse. So this is the septum here. This is the lateral nasal wall. This is that pink mucosa. And you can see, I'm going to play that again here. When the patient breathes in, this whole sidewall just falls right in and hits the septum. And we actually have a grading system for this. We would call this a grade 3 collapse, going all the way to the septum and closing off the nasal airway completely. Often patients with lateral wall collapse in zone 1 will get benefit from breathe right strips. And so what these are, if you don't know, is they actually have a piece of metal or something in them that helps expand and support that nasal airway so that it doesn't fall in with negative inspiratory force. They can be uncomfortable to wear all the time, and some people don't want to wear them all the time. So the answer for some folks who have this chronic problem may be a surgical procedure. What about collapse in zone 2? This is a video of a zone 2 collapse. You can see this is a little bit different. It's lower. It's right on that ala. You can see that margin of what we call the ala here, and it's just falling in. I'm going to play that again. And in this case, it was a result of prior surgery with the cartilage being removed such that this nasal airway was compromised. Why is this collapse occurring? A little more physics. What's happening here is we have an inherent weakness of that sidewall. And when we inhale, there's a negative force that's generated. And if that sidewall cannot compete against that force and negate it, it will start to fall in. And as we get a decrease in area, and we may also have a septal deviation or something in the inside, which is also making the area, that valve area narrower. We get a pressure drop and decreased pressure, and negative pressure generated, and it sort of becomes a vicious cycle and this whole thing collapses. So the treatment strategy here is to increase the area intranasally if possible, and also to resist that negative pressure in some way, shape, or form. Two primary strategies are used to try to do that. And one is to add cartilage to that lateral nasal wall to try to stiffen it as much as possible. And that is probably the classic technique. And this is shown here in this diagram from one of the textbooks out there. And the advantages of this technique are ostensibly that it adds structure. I would submit that at least the way it's shown here, this wouldn't do much other than add bulk to an area that's going to continue to collapse. And in my experience, with rare exceptions, it was not as effective as I would have liked. Other disadvantages are is it adds bulk, and so there's a bit more of a cosmetic deformity in patients who have this done. It has its place, though, but there's another technique which I find more effective. And this technique involves placement of a suture to stiffen this lateral nasal wall, especially up here in the zone 1 area. And it's placed out to the bone and drilled into a small 2-millimeter hole in the bone and permanently stays there and helps stiffen that area and resist that negative inspiratory force. And this is something that we've written about. We've initially described it. It was actually initially described back in the mid-90s, but our approach to it was described in 2006 or 7. And we've done hundreds of patients with this technique. This is our bone anchor. I have no interest in the company. This is just to show you how small this is. This is about 2 or 3 millimeters across, and these are threads or sutures which are present, and we suture those to the cartilage and help stiffen that lateral nasal wall. Just a few comments on functional rhinoplasty. You know, the nasal airway, first and foremost, should be evaluated and treated medically. And I mentioned that earlier. We don't necessarily want to take people under the knife and do surgery. And in many cases, treating the mucosa appropriately can result in very nice improvements in the nasal airway. But in cases when there are structural problems with the nose, a functional rhinoplasty may be indicated. And in this case, the goal is restoration of nasal structural support.